healthcare data innovation and witness the future of patient care unfold. Dive into the Health Data Forum, where groundbreaking advancements and cutting-edge insights await. Explore the transformative power of data to revolutionize healthcare delivery and societal well-being. Join leading experts, thought leaders, and innovators as they delve into the latest trends and challenges. Experience the collaborative spirit of a vibrant community where ideas converge and partnerships flourish. Participate in discussions, share your perspectives, and contribute to shaping a healthier future. Stay ahead of the curve with our comprehensive video library, featuring insightful interviews and presentations. Catch up on thought-provoking conversations and engaging discussions that keep you informed. Together, let's harness the power of data to transform healthcare for the better. Join the Health Data Forum's mission to make healthcare data work for everyone.
Good afternoon, everybody. Thank you so much for joining again for the session in the afternoon. So Hugo Pedrosa is going to be our moderator here, and Hugo is probably also introducing a little bit of himself, but I will tell briefly that he's the person in charge of real-world evidence in IQVIA in Portugal. It's a great pleasure to have him as a moderator. Hugo, please, may you come here?
So thank you, Will. So my name is Hugo Pedrosa. I'm a principal working in the Lisbon office, actually working on real-world evidence locally. And I'll have the pleasure to work on this topic that we're going to be addressing now. I'll have three subject matter expertises that will be working with us, and that will be here with me. I'll have Niels. He'll be joining just afterwards. We had a great lunch just now. And I think that we have also online, and I don't know if we can put them on screen, but we'll have Paola Quatronni and Pantelis Natsiavas. Yeah, we got them both here. Just making a quick introduction regarding the topic that we're going to be mentioning on. So basically, I'd say that this is a really good session, and I'd say that it will complement a lot of what they've been speaking, both in the morning, particularly in the last session, and also what was spoken yesterday. So basically, we're going to be speaking about governance, analysis, and the security regarding real-world data, and what should be done on these areas. So this is quite relevant, right? So what we are saying is that we need to define who sets the standards for the sharing of the data, how can this data be used, and what should be done here. And then we'll definitely need to address, okay, who is going to be analyzing that? We spoke also a lot of that, and it was also spoken yesterday on the panel on, okay, we got the data, but who is analyzing it? Who's making the real usage of that? And for that, we're going to be talking about primary usage, secondary usage. That will be quite relevant. And then in the end, we're speaking a bit more regarding security, and that's also quite relevant, right? We got GDPR, we got a lot of challenges here, and we have to provide those guarantees. And so for that, we will have the three experts that I shared. And then I will start by introducing Paola Quatronni. Can you hear us? Put you on speaker.
Thank you.
So Paola Quatronni, she's the Quality Improvement Director for the European Association of Cardiothoracic Surgery. She's joining us from the UK. And she will be speaking in the first topic regard basically how the cardiac surgery registries, and we say that that's definitely one of the ways of collecting this real-world data, can be used and be implemented, and by all of this, drive what is quality of improvement and data governance in healthcare.
My screen in a second. In the meantime, I'm going to say thank you very much for inviting me today. It's coming. Can you see my screen now?
Yeah.
Perfect. So thank you very much for the introduction and for inviting me today. It's a pleasure to be there. Very interesting discussion so far. So my name is Paola and I'm working for the European Association of Cardiothoracic Surgery. And I'll be talking to you about our work on accessing high quality data to improve patient care and research as well. So first of all, we are the global cardiothoracic surgical community, and we actually want to bring together the professional society and the professional organizations to deliver better skills, better surgery, and better patient outcomes. We want to deliver first-class education and a lot of education opportunities such as training and courses for surgeons and for professionals in this space. We also run publishing services and we facilitate publication in different journals, and we also drive some research. In the context of research, which is probably relevant to the conversation today, we look at how we can better use insight to produce improvements in quality of care for the patients. So the challenge that we are trying to address with this association is really looking at heart and lung disease patients. We know that heart and lung diseases are among the first cause of death in Europe. And many of the patients who have these conditions might undergo a surgical procedure. So understanding how surgery is performed and managed in the hospitals and other healthcare settings is key to improve quality of care. We are trying to invest in the data space to look at how we can maximize surgery and the way that this is done. So we know that using hospital surgical data can provide an opportunity to inform decision-making in the hospital, patient management and care, but also research and innovation, ultimately also improvement in clinical practice. We know that we have registries that are already available across Europe and databases. However, this is this registry landscape is very fragmented, and the information and the data are not used to the maximum potential because they are all collected in different ways. Governance is going to be a key part of that to kind of harmonize processes across different countries in particular. So our approach is really to present and build data platforms that can enable harmonization of cardiothoracic surgery data and governance in Europe for obviously this discipline specifically. So this is our approach, which is going through 4 different pillars in a way. First of all, we want to build connections that are going to be key to get those agreement and consensus statement on governance. And so we bring together surgeons, researchers, clinical registries, and societies. Then we want to create high quality data assets, and which means that we have to identify what are the key priority data sets in cardiothoracic surgery, how can we map those to establish interoperable standards and standardized data dictionaries. And obviously we've been talking about today about this as well. We are also creating the foundations for connected data platforms. And when we say data platforms, those might be both centralized databases or federated databases. But the idea is that we harmonize the processes so that we enable automation, implementation of new technologies, and also enabling AI and statistics on those data. And finally, demonstrating impact is going to be key because ultimately we want to improve patient benefit and improve decision making. So for instance, one of the work that we do is around medical device regulation. So we have at the moment 2 databases in which we are trying to harmonize as much as possible all of the processes that lead to patient data use. The first database is the Adult Cardiac Database, which is a collaborative registry and a benchmarking tool of cardiac surgical data for centers from across Europe, so different hospitals in Europe. And the idea is to support the development of evidence-based guidelines and improve both pre- and post-operative care. This is a new database, so we are still collecting the data from different European hospitals, but it can be used both for quality improvement initiatives and also for research. The second database that we have that has been there for quite a while but needs a lot of revamp, let's say, is a registry that collects data for patients who have undergone mechanical circulatory support. So mainly patients who have advanced heart failure. So we collect clinical procedural updates and scientific data for patients with mechanical support to inform clinical practice through benchmarking, outcome monitoring, and research. And this is a research database which is based on patient consent. So you can see there we have more than 9,000 baseline records, 80,000 follow-up records, and we already have some publications on these. Again, we are looking at reviewing the processes that underpin this database to see how we can align with a newer database and see if we can look at federated models as well in the future. But at the moment, it's still a centralized database. Again, in terms of usage of this type of databases, they can inform trends across European countries, benchmarking, they can inform regulations and decision-making by legal authorities as well. So in terms of data governance, what we are doing for both databases and what we will be planning to do for the future, if we have more of these type of databases, is looking at data across European countries and harmonizing access as well. So the idea is that people who are participating in the database, they also use one single application form for accessing the data. So this is a path that I'm sure you're all familiar with, and many registries or data custodians will use to provide access to data, where a researcher submits a data request. Then that data request is assessed based on basic criteria. But then there is a scientific panel who evaluates application against criteria such as public benefit and sound methodology. This is where we use a specific framework to ensure that there is safe access to the data. And finally, after application approval, there will be a legal agreement in place, and either data access to an environment or data transfer will happen. One thing that I wanted to mention in terms of harmonizing access is also looking at transparency. Transparency is going to be key in the way that we tell people how data is used. And this is something that definitely the European Commission strongly recommends with the European Health Data Space, but also some work previously in the UK have highlighted how it is possible to have standards for data use registers that are registers that tells you exactly how the data is being used. Finally, in terms of framework for data access governance, so basically what we're following for our databases at the moment is the 5 SAFE framework, which you might have heard of, but it's basically a framework that was developed in the UK initially, but it is to assess the people who are accessing the data, the project, whether they are in the public benefit, the safe settings, looking at the security of the settings, the safe data, looking at what data is actually used and providing access to only that data, and safe outputs, making sure that whatever is coming out of a secure environment cannot be identified to find data subjects. And then on the right again, I'm mentioning the European work because a think tank report has showcased how we can improve governance by implementing frameworks. However, the practicality and implementation rules will need to be assessed and need to be seen how it can be done across different countries. But the change is happening across the different countries, and I think there are already some good examples of this that we can see. So I think I'm going to stop here, and I think I ran out of time, but just to say thank you, and I'm hoping we have a good discussion.
Science is joining us from Greece, and you will be speaking more in what regards to the integration of technology in real-world evidence. So, Pantelis, the floor is yours. If you can share your screen, that I think you already are.
Can you see my screen?
Yes, now in full screen. Yes, great. Thank you.
Thank you very much for the invitation and the opportunity to share my experience from integrating a real-world hospital, as I would say, in the realm of real-world data analysis. I am saying this to note that while very interesting initiatives have already been presented today. We had very nice talks from Harvard University in the morning, and then also some very good European initiatives, very important European initiatives have also been presented. But still, in my view, we have to keep in mind that not all hospitals, not all real-world healthcare organizations can really follow up this pace. So I'm going to present the case of the Papageorgiou General Hospital, which is a big hospital in Thessaloniki, northern Greece, where I don't work for the hospital. I work for a research center, the Institute of Applied Biosciences, for the Center for Research and Technology Hellas. But in collaboration with this very big hospital, we have converted their data in OMOP-CDM, the data model that has already been mentioned, getting funding from the EDEN project that has already been mentioned. And now we are in the process of getting on board with the Darwin initiative from the EMA to facilitate the analysis of this data. So what do I mean by the term real-world hospital? So now we have here a hospital which has a lot of data. In this case, the main hospital system has data from 1.41 million patients, even more. They have an EHR system which is operational for years now, but utilizing the real-world data is not a priority. We come from Greece, which is practically a bankrupt country. So investing on state-of-the-art technology is not a priority because there are other more crucial priorities. So there is no data science team in the hospital, and there is no specific funding for real-world data analysis. This means that beyond this lack of funding issue, we also had to deal with legal issues. The legal context is not always mature, not in all countries at least. We all hope that the European Health Data Space Regulation, the European Health Data Space Initiative, could facilitate all these issues also in countries who do not pioneer on these things. There are administrative processes, new administrative processes to be applied in hospitals that are not really familiar with these kind of things. And still funding is always an issue, of course. So what we managed to do here is through collaboration, through a steady collaboration between a public research center, the INAPSER, and the hospital, we managed to transfer some of the know-how, because we as a research center, indeed, we follow this community, the Odyssey community and the real-world data analysis community, and we have the know-how. And we have also managed to facilitate networking between the hospital and various stakeholders who could provide some funding, like the EDEN initiative that has already been mentioned, which is a very important initiative. It has managed to build a network of almost 200 hospitals across Europe, almost 200 data sources across Europe to have their data ready to analyze. This led us also to participate in the so-called mega study. There is a very big study going on to analyze real-world data coming from hospitals, focusing on the lack of specific medicines in Europe. So beyond that, we managed to get on board with the EDEN Foundation, with the Odyssey community, with the Darwin initiative from the EMA, and this is something that provides us the funding and the necessary means to work on this kind of data. The next step is to attract some funding. We hope that we could attract funding also from industry, from pharma industry perhaps, and start working on more technical issues, on more technical innovation issues. Summarizing here, I would like to emphasize that there are indeed a lot of practical challenges, but there are also ways to overcome them through collaboration and correct networking. There are European funding schemes which could facilitate the analysis of real-world data, even in low resource settings, sometimes, if I may use the term. Thank you.
Thank you, Pantelis, for your presentation. I would like now ask to Niels Bolding to come to stage. Thank you. So Niels is the technical lead for Health RI in the Netherlands, and he's been more than 30 years on technical consulting, but the last 10 totally dedicated to health. Sure. And now he's going to share with us a bit what's happening in the Netherlands and the institution that is leading, and also speaking a bit about the healthcare infrastructure and now that component is so relevant. So the stage is yours.
Thank you.
I think the tech team will share your presentation here. Do we have to do anything? Open up.
Let's see. Thank you very much. It's here. Yeah, that's there. Okay. Thank you very much. Indeed, my name is Niels Bolding. I'm from Health RWE, and we're from the Netherlands. Health RWE, the RI stands for Research Infrastructure. So we are all about the health research infrastructure. We have a mission as Health RWE. We try to better health of citizens and patients by reusing health and life science data with an integrated data infrastructure, and that's where I come, to enable data-driven research, innovation, and policy. So that's more or less our mission. We are an organization funded by a growth fund, so mainly subsidized by the government. And we have a main task to orchestrate a national health data infrastructure for research, policy, and innovation. So also called secondary use. And fragmentation is already been mentioned a lot, and that's what we try to prevent. What you see over here is a picture of a typical Dutch situation. We call it TURPS. A lot of our Netherlands, and Netherlands means lowlands, is below sea level. So before people are building a house, they need to build a hill to keep their feet dry. And so every time, to make this metaphor to data industry, every time someone, a researcher, wants to have their data for a certain illness domain, they first have to build their own infrastructure and make all kinds of interfaces with all the EHRs to get their data. So building this TURP before doing the statistics and the analytics. And we would like, what we are proud of in the Netherlands, we call it the Delta Works. Those are dikes all over the country, which is being made by the government and which will keep our feet dry. And when a storm comes up, we raise certain dams, so we are certain that most of half of our country stays dry. So if you want to build a house in the Netherlands now, you don't have to worry about building a TURP before building your house. You can directly start building your house. So in the same metaphor, we're trying to create an infrastructure in which we try to make health data available for multiple use, so that you don't need to create your own infrastructure before you can use it. To do so, we started in 2022 together with some organizations, and the ministry is on top of it in the health sector itself. We tried to create an architecture for our infrastructure, and they were afraid that we were going to build a new one again. But no, we don't. We want to collaborate, and we want to come with one generic infrastructure, with one generic architecture for this infrastructure. So high level, we came up with this picture. On the left-hand side, you will see all the multiple data holders, all the different kinds of data holders, like the European health registries at the top, we call it EPDs, electronic data capturing tools to represent research, for instance. So on the top, we have our real-world data from the hospitals, from EHRs. Not to explain everything in this picture, because I can talk a long time on this, but to keep it short, main important thing is that we want to have one single solution, and all the generic features like identification and pseudonymization, we want to solve them as generic features. So every organization is using it in the same way. And then the left-hand side, we have the users on which we try to get a data-centric approach. What we mean by that is that on the top left, the EHRs, each EHR in the Netherlands almost has their own information model. So we have 7 universal medical centers and over 150 hospitals. So we and the GPs. So I think we have more than 200 different information models. So what we try to do is harmonize and standardize those. That's been heard a lot already today. So I think that's really the key. But this harmonization and standardization is not being done in the sources themselves very soon. So what we try to do is create a middle layer in which we transform this data to this harmonized setting. And while we did do so, once we did so, we can ask the software suppliers of the EHRs, please do it like this in the future for us, so we will not need this middle layer anymore. And we try to standardize the technique, like the interfaces. So all the applications at the right-hand side do not have to think, what kind of organization am I talking now? What kind of techniques do I need to use now? So we want to use one technique. In the care system themselves, they decided already to use FHIR and to use SNOMED as standardized interfaces. So that's been taken care of, but what we are going to do in the secondary use, I will come to later. In the past 2 years, there was a nice initiative also stimulated by the government, which is called Cumulus. And Cumulus is an initiative which concentrates on the top left side. So all the data coming from all these more than 200 information systems, they try to standardize those to a certain information model. That's a project which will start, and they try to have the standard interface, FHIR, I already mentioned here, to make the data available for the care services themselves. And the care service is only interested in the data of one patient. So that's why I mentioned N is 1. We only deal with one record. So I more or less compared by a glass listening to the wall. As secondary use, I want to have a glass listening to the wall and all the data which goes through this pipeline of primary data. And I want to tap that information, but we are not interested in data of one client. We are interested in a set of clients. We are interested in data sets. So N is bigger than 1. So there are some challenges when we're going to ask Cumulus to make their data available for multiple use, for secondary use as well, because then they also need to make their data findable. And we are using a mechanism called fair data point to do so, to make data findable. So this fair data point can be harvested by catalogs, any catalogs, because it's a standard way. This again, the data holder only has to make it available once, and it can be used by multiple purposes. So it can be used by multiple catalogs. And they have to handle the requests if they want to use the data. If the request is granted positive, then they have to minimize the data, that only that data has been available, which is needed for the research, not all the data, but only the applicable data. So then we minimize all the columns. But we also have to minimize the opt-outs. So all citizens who say the data which is about us cannot be shared with other parties, those records we have to minimize, have to get out of the set. We have to pseudonymize the set, and what I called convert within the data definition. In the standardization of data, coding ways and modeling ways, of course, there are different applications. And some applications like statistics will need other ways of coding, like ICD, than the caretakers themselves who are used to work with SNOMED. So we do agree upon that there will be different ways of coding. We try to minimize them. And we want an active, harmonized data mapping system to do so. So these are the features real-world data organizations needs to prepare before real-world data could be made available for secondary use. And to end up the presentation, I will give you the orange picture of the same model in which I focus on the research. So now on the right-hand side, I elaborate a little bit more for research. The left and the bottom is almost the same. And on the right-hand side, for the research, we try to create an ecosystem. So every new research, the results of every new research should be reusable from the start. So meet these requirements of data standards and meet the FAIR principles. In the Netherlands, we have a saying that you want to mop, that you are mopping with the tap open. That means you try to solve problems and new problems pour in. So we try to change that in mopping with the tap closed. So we try to focus on all the legacy data sets to make them applicable for multiple use and hope that all the new researchers will meet the standards for reusability. So that's more or less what we try to do in the Netherlands.
Thank you. Okay, so thank you all. Okay, so for the great presentations, I would try to go a little bit back from the three topics that we want to mention, right? So we want to talk about the governance, we want to talk about the analysis and the infrastructure that we have around RWE. And I think that we have already, even in all the sessions and here and now again, we all saw that there are already a lot of technical solutions, okay? May have their challenges, but there are already solutions for the harmonization, for the data to be available. So assuming that we already have a lot of that going, what we also see is that some of the constraints actually rely on the governance side, right? Who authorizes the access to this data? Who can actually use this data? What is going to be used this for? And so what I wanted to try to understand is a bit from your side and the different realities that you all got. And maybe Paola, starting with you on the reality that you got from the registry, from how that registry actually can be used, for instance, for secondary uses, for secondary research. You had like a flow chart of the process actually of the how that could be asked, right? It's in terms of the different steps, but maybe try to understand a bit more on that. And then I would ask also to Niels and Pantelis to comment on this because they have different views and different systems and different layers within the system. So it would be good to have your view on that, starting with then Paola.
Thank you. Absolutely. And yes, we all have different systems and it's quite actually interesting to compare what can be learned from each other. So one thing to say, in our case, obviously we're talking about a relatively specific use case. So we are collecting data from different hospitals. So that is already a difficult thing to do because we need to harmonize the way that the data gets to the registry. But at least we focus on a specific type of data. And so that is already an advantage in a way. If we're talking about all of the electronic health records, it's much more difficult. We're talking about another scale. But in terms of what we do, and I think that's been said many times, hospitals may collect data in different ways in different countries. So when we are looking for the data set, despite asking for the same data, that comes to us in a very different shape and form. So there is a lot of manual work that we need to do for data curation, mapping to the common data model, and then ingestion to the database. So that is already one of the things that we have found ourselves having to do quite a lot in terms of supporting the hospital and the data managers, etc. But in terms of
is there like a central committee that analyzes like the requests for the data usage?
Yes, in terms of requests, so there are two different use cases for the databases. One is quality improvement. And so people who are submitting the data to the database, they already have access to some specific tools, interactive viewers that we have to analyze the trend of their hospital. They can compare and do benchmarking between their hospital against the hospital in other countries. And that's something that they already have access to. Or whoever is participating can have access to those interactive viewers, but they don't see the patient data. It's aggregated. In terms of external researchers, there is a mechanism and there is a scientific committee, as you said, that will have to go through specific criteria to analyze the proposals.
Okay, thank you. Pantelis, I don't know if you can share your reality on your institute and how is this done? Because actually, and you also mentioned that you are already collaborating in Eden and different areas. So also, how are these requests being developed? And actually, who is also doing this? If it is within your institute, if it's outside of it, how is that working? And then I would ask Niels, how do you do it more on a central body that actually is trying to do that for the Netherlands as a whole? Pantelis.
Actually, in our case, we have to get a permission from two bioethics authorities. One of these committees is for the institute and one is for the hospital. So this is the first step. But beyond getting the permission, beyond examining the protocol and making sure who is going to have access to data, which practically is not really necessary. I mean, the technical tools allow us to prevent access. I mean, there is not a real need for the researchers to have access in the real patient data. They can send their queries and not necessarily have access to the patient data. So this is a very important thing. It makes our lives easier. So not technically though, but in terms of legal access, it makes our lives easier. Another thing that I would also like to point out is that in order to make something meaningful out of this data, though, you don't just need permissions or engineers who could run queries or researchers who could transform a research protocol to a research question and then to an OMOP-CDM query or a script to run. You also need collaboration with the real data curators who are the local clinicians. These are the people who enter data, and when you see a gap, when you see something that seems wrong, there is probably a reason why these data are there in this form. So you need to have an active collaboration with the local doctors. So even if you get a permission from a bioethics committee, if you have not set up an active communication with local clinicians who are the ones who actually enter the data, this is something that it's very, very good to have. It's if you want to make something impactful out of this data.
Yeah, thank you. Niels, do you want to comment on what's happening in Amsterdam?
Yes, sure. In the Netherlands, we divide this problem in two. First, the data custodian, the data holder, who is responsible that their data they are guarding is used in the proper way. So in this case, they feel they need to have a data access committee
Central data access.
No, per data holder. So for per data source, the holder of the data feels himself responsible to have a saying in this. We are looking at the central way to see if data over multiple sources has been requested, that we also will guard if the combination of these sources will lead to vulnerable data. So we're also looking at the central access committee. But currently in the Netherlands, it is decentralized per source. But we are also, which I didn't mention yet, we are also part of the HDAP-NL project, the Health Data Access Body, which is being required from the European Health Data Space Act. So in that, saying in 4 or 5 years when this becomes operational, this Health Data Access Body will be the central body which will determine if a request should be granted or not. So that's the first level on data set level. And then you have, of course, the record level in which the data subjects have a saying also what's going on with the data, which describes them. So there we try to create a central consent registry in which in one place the civilian can administrate the different consent rules for primary use as well as for secondary use. So this registry has been checked just before sending out the set, that these opt-out records will be filtered out before sending it. And of course, we are also working with two ways of sending the data. As also been said in Greece, we are also using the federated approach, in which the data will not be sent to the researcher, but the researcher can send the analytics to the data, and only receive the aggregated data as results back. But we also have something like secure process environments. It's also something the ESCS is talking about. Those are environments which are categorized as not being able that data will leave this environment. And so this is a secure environment where in a limited time span, a limited amount of people will get access to the data, and all these administration will be in the request form. So we want this data for this period, and these people will get access, and those will be granted by currently the local access committee, and in the future by the central health data access body.
Yeah, I'm also asking this because this is a central challenge, I think, that also rises, but also an opportunity that rises when EHDS comes, right? And we have to have that central body defining that. I can share, for instance, in Portugal, we still don't have that defined. And so there's always a challenge there. And definitely what you're working on makes total sense. Then going a bit and picking up on actually in your last words, you also spoke a bit of the way that we are using as a federated model, right? Whereas there are others that are more centralized. We are actually even over lunch speaking a bit about of that. And that, for instance, I was providing the example of Portugal, where we got a more centralized body, so on IT, that actually implemented an EHR that is used by most hospitals in Portugal. Whereas you were saying that, for instance, in Netherlands, not as much, right? It was more spread. How do you see these, for instance, the initial point, so in terms of the EHRs, being more centralized or more decentralized, and now that goes in with the federated model that you're now also picking on? And I would also ask you, Pantelis, on your side, because you are also saying that you're using this, for instance, using the Odyssey and also in the Darwin space, so using these federated models. So probably I would ask two of you a view on this dichotomy of if they can work more together. It's for more on a national level. When we move to the European level, if it's different, how do you see these two being more close, more separate, if they work together or not? How do you see it?
A lot of questions. The case of federated analytics is that the source will need compute power to do so. We'll need the facilities to handle Dockers and to do the aggregation and only send aggregated data. And not every institute has these facilities. So we're also looking at collaborative environments in which a third party can do this for them out of their name. So this we call it spaces. In this environment, there will be a space. The data goes to that space, which still is owned by the institute, but serviced by a third party with compute. So the data goes to the cloud. That's difficult because some organizations don't want the data leave their company, but it's still, the cloud environment is still owned by the institute, and then it can be handled by this centralized organization to do this federated.
Yeah, because there's a huge impact on the infrastructure, right? So using one way or the other, the impact is enormous. Pantelis, what's your view on this?
I think that there is no real dilemma. If somebody wants to run an impactful real-world study, he or she would need to have data from multiple centers, probably across Europe. So I guess that the federated approach would be the main path to pursue a real-world, an impactful real-world study. I am not really sure how things are going to work in the future. As it has already been mentioned, national health data access bodies are currently being built. In Greece, there is always a health data access body being built, being funded by the European Union. but we don't really know how these things are going to work when they become operational. Today, I think that people prefer to work on an ad hoc basis. This has its own challenges. For example, while we know that somebody might have, an organization might have his or their data in almost CDM format, we still cannot really guarantee that all the data that we would like to be there are really there. So we would need to have some feasibility steps, some feasibility studies to be conducted before adapting the protocol before creating the final protocol. These are technical issues which, at least for now, are not really are inevitable, are part of the process, and they cause some burden. But I think that there is a very good basis that we could really work on. There is a big network of data sources across Europe. EMA Darwin is a very good example, is a very good success story, I would say, on how these studies, how these data could be useful and impactful in the European level.
Yeah, Darwin has the federated model, right, where the information is shared. Also, even in top of this, and one of the things that was also spoken was that, okay, we know that AI is entering, so real world evidence already, I would say, a reality. AI is also now a reality, and this will push our infrastructure, because we're saying that we speak a lot about big data. We speak about, okay, all the volumes of data that have to be processed, and AI will also impact these, both in the primary usage and also on the secondary, right? If we want AI to help us predict something, if we want to, in terms of the outcome of a disease or the eligibility of a patient for something, or in secondary usage for the identification of some, there's a huge focus on the processing of all of these data. So what will be the impact of these on our models, Niels?
AI looks very clever, and we had some discussion in the past with AI specialists, like we're talking about this harmonization of data and the standardization of data. So we had a discussion, will we still need to harmonize and standardize the data if AI can understand it and can do the harmonization themselves? And the answer is yes, of course, they can do so. But if we give AI standardized information, the results will be better than if you give them unstandardized. So by starting with standardized and trying to learn them, then the AI results will be better. But you can do AI also without, but then the results will be less.
Yeah, so if the starting point is better, then we'll be able to also to get better. Any point on your side, Pantelis, before I move to Paola?
Well, the AI is, of course, a key technical development. We need to use it, and we will. However, before being able to use AI, we should really consider the quality of data. As it has already been mentioned in a previous session, some data might be great for a specific use case, for a specific scientific question, but not that great for another one. So we need to, if we are going to trust this data to build algorithms that are trustworthy, we need somehow to make sure that we have the necessary data quality level, which is not an easy thing to be sure for.
Yes, quality is always a concern, right? When we're talking about AI and what is the AI giving us. Paola, you wanted to comment?
Yeah, just very briefly, and I completely agree. And again, the time that we spend looking at data quality and curation, even for our network, is huge. But one thing on AI and quality actually that is linked to it, if I mention as well the importance of data to be inclusive and actually data to be a representative of what we want to study, of the populations. Because again, models and AI trained on non-inclusive data could be a problem. So I think that is one of the pieces of work that we need to do. And I think there are a lot of works doing, looking at how we can collect inclusive data and improve data collection to make sure that we embed all of the population and not, and we're not biased.
Yeah. So we speak about governance and we speak about the infrastructure, right? And also the impact of AI. Just, Paola, also to have a view on your side more regarding the analysis itself and basically what is done, and we're talking about the registry and basically what is done, I assume, in each of the countries, right? In each of the societies that actually collaborate with you, but also what is done on your side and a bit of, for instance, in the morning, we also spoke, so all of these will need human resources. So we will need teams to process this information, teams to analyze this data. Also, how do you manage, so on your side in the association, how do you manage this analysis and what comes up?
So yes, in terms of the type of analysis, some of them might be around quality improvement and might be looking at trends of using a particular procedure across countries. And it's actually very interesting to have data from different European countries together. It is a centralized system, but it's very curated. And the good thing is actually that we are using multiple sources data. So that is quite good. And I think the added value of that for some of the surgeons and the doctors who are using the data is really the fact that they can compare their own hospital data with the European hospitals at the aggregated level, so that they don't see names of what surgeon is doing, what surgeon is doing what procedure, but they can compare how the trends is going. We also have the added value of bringing them together and compare their analysis so that they can learn from each other, because for us, the main purpose is really driving quality improvement at the hospital. So if an hospital realizes that, for instance, they are late at performing specific procedures, and then they share their knowledge with another hospital who does better, then they can learn from each other. And I think that's particularly important, and it's our mission to actually improve the practice at the hospital. Yeah.
Okay, I would like to thank you all I think we are on time. So I'd like to thank you all for your presentations and also for the debate. I hope it will also help the audience to know a bit more about the governments, the usage of the data and the infrastructure that we will need to process it, depending on the different models. So thank you all, and Paul, back to you. Thank you.
citizens in order to provide better health care and better interventions to promote their health. There should be some kind of, let me pull the topic to my field, public health information system that could gather all this information and that could link between healthcare providers, researchers, political deciders, that we can all see the benefits and the important effect that real-world data can have in every one of our aspects.
What if you could be part of a revolution that transforms healthcare as we know it? Welcome to Digital Health Portugal, where innovation meets collaboration. Our mission is to foster the transformation of healthcare systems by promoting open dialogue, civic engagement, and the adoption of innovative technologies. Imagine a world where patient outcomes are optimized and healthcare delivery is seamless. Our Digital Health Manifesto is the strategic framework guiding this transformation. Our events, seminars, and workshops create momentum for sharing and discussing health-related ideas. Experience the power of collaboration at our quarterly meetups. Portugal's thriving startup ecosystem is reshaping the digital health industry. Our products and services are uniquely created to match your communication goals. We are the most relevant civic engagement platform for health innovators. We partner with Forum Hospital do Futuro to foster a sustainable national health service. Our think tank, SNS de Contas Certas, is committed to driving the transformation of the National Health Service through open dialogue among public, private, and social sector stakeholders. We encourage knowledge generation and support policymakers in understanding health ecosystem needs. Be part of the movement, advocate for change, and co-create the future of healthcare. Our members are united by a shared purpose to drive meaningful innovation and transformation in healthcare for the benefit of all. Dive into our podcast to uncover actionable strategies from our think tank plenaries. Join our LinkedIn Live sessions for engaging discussions with healthcare leaders and innovators. Join us at the Health Data Forum Global Hybrid Summit to shape the future of health data. Our goal is to raise the excellence of the Portuguese healthcare ecosystem internationally. Be part of the digital health revolution with Digital Health Portugal and make your mark.